Hi and welcome to my podcast, the Fertility, Motherhood and Wellness Show, True Stories with Dr. Rajeev. Through this podcast, I will be dealing with issues related to fertility, safe motherhood practices, as well as women's health. Welcome back to our three-part series on endometriosis. In the last episode, we discussed about the basic problem of endometriosis and how we can diagnose the problems. In this second part, Dr. Apoorva and I will be discussing the management of endometriosis, especially from pain perspective. Dr. Apoorva Pallam Reddy is a gynecologist, IVF specialist, laparoscopic surgeon, and aesthetic gynaecologist from Bangalore. She is the editor of several books, author of innumerable chapters on gynecology and infertility, which serve as a teaching reference for budding young gynecologists. She's on the Editorial Board of Journals, where other researchers send articles to get their work published. She's a regular speaker at various national conferences and has been invited as a speaker right from Pakistan to Malaysia and from Europe to Sri Lanka. We work together on many projects, including hosting a series called What Women Want on Instagram, as well as an academy for training young gynecologists in infertility called International Fertility Academy. So thank you once again, Apoorva, for doing this together. This is a rather difficult topic, and I couldn't have handled this topic without you. Over the last few days, I've been receiving innumerable messages as well as calls related to our first episode, and everyone is eagerly awaiting our treatment episode. So here we are.
Absolutely. Thank you so much for having me here, Dr. Rajeev, and for all the kind words. All the chapters that I have written, we have co-authored, and all the books that I have published, we have co-edited. So yes, I think half the credit for all the work that I have done goes for you as well. And coming back to endometriosis, yes, I think it was definitely a needed thing that we had to do this podcast on endometriosis in 3 different parts. That itself explains as to the enormity of information that should be reaching our clients. So yes, I think it is very, very important that we address the pain aspect of endometriosis.
So if there is one symptom which defines endometriosis, it is pain, recurrent or persistent, but debilitating pain. Pain that changes lives, destroys daily lives, careers, and more importantly, wrecks the mental framework of even the most sane women. One of the questions which came to me was, how do you doctors approach the treatment for such a patient with endometriosis? So, Apoorva, would you like to answer that?
Endometriosis is a chronic disease. In that sense, there is no cure for endometriosis, but the symptoms can be reduced by the right treatment. As we discussed in your previous podcast, where we told that most of the times endometriosis is caused because of the retrograde flow of menstrual blood into the body. So it technically means that as long as you're having your menstruation, you will still have a possibility of getting endometriosis back or it worsening from what it is right now. And to communicate this with our patients is probably the key factor in treatment parameters per se, and only understanding how their pain works, that's the best way for us to evaluate what kind of treatment works for them. You will need to discuss your options with your doctor and, ask as many questions as possible and, clear all your doubts that you have regarding the condition well in advance.
Very true.
Women with endometriosis have either pain or fertility related problems or, worst of all, they can have both. So treatment of endometriosis focuses on resolving or reducing pain due to endometriosis or improving fertility. Now, we need to understand that depending on the patient and what they want, the treatment can be different. Your doctor will take several factors into consideration when prescribing medical treatment or advising a surgical treatment for you. Now, these factors would include the preferences of women, of course. In case if you really do not want to go ahead and have a surgery as your first option, you might consider taking medications in the beginning. The type of disease, of course, in case if it's a peritoneal disease, ovarian cyst, or deep endometriosis, especially for ovarian endometriosis, is what we recommend surgical options for, especially ones which are quite big. The severity and type of symptoms and type of pain, of course. The wish to become pregnant immediately or at a later stage. Most of the women, would want to kind of have a pregnancy at some point or the other, but based on, their preferences, it can happen right away or, at a later time. The costs and side effects of some treatment, age of the women, treatments that she's already received, and of course, the expertise and the area the doctor is also. Some endometriosis surgery sometimes can be extremely challenging and complicated. I would say very few good laparoscopic surgeons also have difficulty in managing it very well. What do you say, Dr. Rajeev?
Absolutely, very, very true. So centers which are handling a lot of endometriosis and doing a lot of laparoscopies on them would have a different expertise as compared to someone who's not handling so much of expertise. So in many countries, there may not be so much of endometriosis as much as what we see in India. Exactly. And even in some parts of India, we discussed in the last podcast as well, that South India sees more endometriosis.
Definitely.
So yes, there would always be a regional difference.
Yeah, and it's also equally important that when we are operating first, it needs to be done well, because this is not the kind of surgery, you want to keep doing again and again. So this means that two women with endometriosis could receive different treatments, and even that one woman could receive different treatments over a period of time, depending on her preferences, her age, her wish to become pregnant. And most importantly to remember is that medical treatment works only when they are taken as prescribed. Stopping medical treatment often means that the symptoms are going to recur. As you said, Rajeev, pain is the most predominant symptom. Why don't you throw some light on strategies we employ for relieving this pain?
So what people need to know is that when it comes to pain relief, most strategies are effective. As you mentioned above, we will choose a therapy which fits closest to the need of that patient. So there are several medications which are used to relieve the pain. These can range from over-the-counter remedies to prescribed medicines from the doctor. In more severe situations, the patient might be referred to a specialist pain management team.
True.
In the most simplest form, a tranexamic acid and a mefenamic acid combo works really well to reduce both flow as well as the pain during the periods, and is available over the counter and can be safely taken up to 3 times a day and can be taken every month without much side effects.
True.
So for those whose pain is more severe, more drastic measures are needed, like say maybe hormone treatments. So these treatments reduce or stop ovulation, that is the release of an egg from the ovary, and therefore allow the endometriosis to shrink by decreasing hormonal stimulation.
Right.
So let's talk about some of the hormonal treatments that might be offered, which are usually contraceptives and which will also stop you from becoming pregnant.
True.
So this could include the combined oral contraceptive pill or the patch given continuously without the normal pill-free break. So normally we give an oral contraceptive for say 21 days or 28 days, give a gap and then start again. So in these cases we give it continuously. That's what the patients need to know. This usually stops ovulation and temporarily either stops your periods or makes your periods lighter and less painful. The other hormonal thing that we use is an intrauterine system called Mirena, which helps to reduce the pain and makes the periods lighter. Some women using the intrauterine system get no periods at all, which is brilliant for women with endometriosis. It is very easy to insert and works for 5 years. For women seeking long-term benefit from pain and who have already had children, this is my absolute favorite. And I'm sure, Apoorva, this would be your favorite as well, because
True.
there are no side effects, and once inserted, the woman is brilliant. I mean, she really goes through life very, very easy. What say?
Definitely, definitely. I think what our listeners need to, take back from this point is essentially endometriosis is happening, one, of course, because of the retrograde flow happening from your menstruation, and two, estrogen-rich environment kind of adds like fuel to fire. So if you already have endometriosis and if you have a lot of estrogen in your body, it's going to make your symptoms worse. So all the treatment options, like Dr. Rajeev has been telling, they are essentially to cut down the estrogens in your body, and Mirena is a great progesterone releaser, and that's the reason why the symptoms are, resolved very effectively with the use of Mirena.
True. So beyond this, we can also use progesterones in the form of tablets, which are given either daily or injection, which needs to be given on a 3-monthly basis. So 3 monthly injections can be given. Not exactly very popular as a choice because of few side effects. We're not going to get into them right now. The other injection we can give is a GnRH analog or gonadotropin releasing hormone agonists, which are given as injections on a monthly basis. Very, very effective, but can cause menopausal symptoms when given for more than 3 months. We, of course, use them extensively for women battling infertility with endometriosis and undergoing IVF, since use of such injections before the embryo transfer increases the pregnancy rate. So, you and I both use these GnRH analogs very, very commonly in IVF.
True.
But then again, that is not something we give to women for long-term therapy, because when you give it for more than 3 months, it causes the bones to kind of become more brittle and stuff like that. There are more side effects. So long-term wise, no, this is not a very great idea. I personally like to start with the oral contraceptive first to see if the pain is getting relieved and that the treatment is working. And if I see that happening, over a couple of months, then I switch over to the Mirena system, since that does not require any daily medicine intake, is equally effective, and needs a change only after 5 years.
So all these pain medications and Mirena or oral contraceptive pills, these are again I feel are commonly accepted by clients for use. But what about Dynogest? The medication which is very, very specific for use in endometriosis. What's your call on use of Dynogest for pain management?
Dynogest is very good, but as I said, all medical managements are the same. You could use any one of them and it doesn't really matter. And of course, Dynogest is very, very specific for endometriosis.
Right.
I'm not a great fan of Dynogest only because it causes spotting in the initial couple of days, weeks and months. And that sometimes becomes a bit of a painful thing for patients. If I give Dynogest and I could continue that for 5 years, I would still be all right that, okay, after some time it's going to settle down.
Right.
We normally don't give Dynogest for more than 2 years.
True.
So in my opinion, I would go with an oral contraceptive pill in the beginning and a Mirena later on, as compared to a Dynogest for maybe 2 years.
Makes sense. It definitely makes sense. In case if the pain is reducing with either OCP or a Mirena, then I think that's the best way to move forward. But if not, then probably we can always consider the option of Dynogest.
Absolutely. So Apoorva, what is the role of surgery in women who experience pain?
Now imagine this, someone is coming to you for pain and you tell them that, we need to operate you to get rid of the pain. It's going to sound, very weird for them as well, especially in case if they don't know that they have endometriosis. But, surprisingly, surgery has a much larger role in women who are not looking towards fertility than in those who are. Well, we, of course, we will be touching regarding the fertility aspect of it in our next podcast, so I won't elaborate that here. But for women with endometriosis, surgery can be in various forms. If you are performing a laparoscopy for some other reason and we find areas of endometriosis, then it's prudent that we actually remove or destroy those areas so that they don't grow larger with time. This is what we would say a diagnostic laparoscopy, when all scopes of options for pain in the women have been eliminated, and despite that they do have pain. So in order to make a diagnosis regarding why they are having that pain, we do a surgery, a diagnostic laparoscopy, and whatever endometriotic spots we do find in that procedure, we kind of eliminate it at the same time. So it's like a see and treat kind of situation. Secondly, if we find large endometriotic cysts, they will need removal as they do not respond to medications well, and any sort of other therapies. The surgery needs to be combined with other long-term therapies like either Mirena to consolidate the results achieved with the surgery. Otherwise, in just another few months, the disease or the endometriotic cysts will be right back. This is a major area of concern since in most cases that we see, the surgery is an isolated procedure which is done, and in just a few months we see a patient's coming back with even more severe symptoms. The most common question I think most of them will ask is, once we get the surgery done, is it going to be gone forever? So I think that's what people would ask of you as well, right, Dr. Rajeev?
That's a very, honestly, both doctors and patients need to have a realistic view of what they can achieve out of the surgery. Unfortunately, there is, kind of a gap here wherein some surgeons are brilliant surgeons. I mean, they do a fantastic surgery. But then they fail to sometimes tell their patients that, look, this is going to come back and this needs to be now followed up with other things. And patients as well feel that they were suffering terribly with pain some days back, and now after surgery they've become better. Even if their doctor did advise them something, they said, oh, you know what, we're feeling good right now.
True.
Go back to the person again in some time. And before they know it, everything has come back.
True. So I think it is important to kind of stress just not on the surgery, but having a very effective follow-up treatment plan as well. So sometimes the surgery is performed because other methods are unable to relieve the pain, or other therapies are causing too severe side effects. So surgery manages to release the adhesions that are there between the endometriotic cysts and various other intestinal organs. But again, this is only temporary because eventually in the long term, they are going to come back. Sometimes the endometriosis is so advanced that it causes problems to the surrounding structures in the body. Like for example, it may engulf the ureters, that is the pipes that actually carry the urine from your kidneys to your bladder, and thus cause obstruction. And if they are not released, they may actually destroy the kidneys. We usually find hydronephrosis or hydroureteral nephrosis. That is what ultrasound finding shows as. Now, the disease may hinder smooth functioning of the bowels, and this could be a reason for surgery too. A lot of women have severe constipation or have very severe pain while passing stool, and all of that is because of an endometriotic cyst that is there very close to the rectum or to the bowel.
Sure.
Lastly, sometimes we need to operate just to prove that the problem is endometriosis and not cancer. Endometriosis does not lead to cancer, but the differentiation between the two may not be very clear from an ultrasound and other basic tests, and thus a biopsy is needed. I must of course add that surgery, whenever performed, must be done laparoscopically and not an open surgery.
True, this I think is a very, very important point.
Right.
That it should not be an open surgery. You're only going to cause more problems. There are already adhesions inside because of endometriosis. You do an open surgery, you will add more adhesions inside and cause more problems to the patient.
And the kind of magnification that we can have with laparoscopy and the kind of spaces that we will be able to enter in a laparoscopy, I don't think we'll really be able to achieve that in an open surgery.
True.
So Rajeev, what is your opinion regarding alternative therapies? All patients kind of keep giving us recommendations.
I think this is a very difficult topic, subject to really talk about, especially we, from the allopathic practitioners. But I think what I believe deep down inside me is that no therapy or no practice is good or bad. There are certain things which are brilliant in the alternative therapies. The problem is finding that right person who knows his job For example, Ayurveda has existed in our country for centuries, and I'm sure there are brilliant therapies present in Ayurveda for various kinds of diseases. But to find the right person who knows his job is going to be the more difficult task. So some women have found the following measures quite helpful. Exercise. So some women swear by exercise, yoga and whatsoever, and they feel that it improves your well-being and symptoms of endometriosis. Some people have said that their pain went completely away because of yoga. Or cutting out certain foods such as dairy or wheat products from the diet. I don't know how it helps, but then some people have swear by this as well.
True.
Psychological therapies and counseling is definitely required because there's so much happening around the lives of these women in terms of pain and fertility and everything else, that probably these women do require some sort of hand-holding in another way.
True.
So regarding the complementary therapies, although there is only limited evidence for their effectiveness, some women may find the following therapies very helpful to reduce the pain and improve the quality of their lives. So reflexology, maybe you just press certain points and pain because of the endometriosis might actually become better. There is something called TENS or transcutaneous electrical nerve stimulation.
Right.
It again works brilliantly. Both you and I know it's used for various kinds of aches and pains. For listeners, what essentially it does is it causes certain nerves stimulation. And when those nerves are stimulated, when they carry a message back to the brain saying that we are getting stimulated, the other nerves which were supposed to carry the pain from endometriosis actually get suppressed. Pain from the TENS passes through, the pain from endometriosis does not pass through. Right. Acupuncture. Again, some women have had great relief, but finding the right person to do the job probably is difficult. Vitamin B1 and magnesium supplements have helped. Some people swear by, again, say traditional Chinese medicine, herbal therapy, homeopathy again. Some people say they're false treatment and wrong treatment, but I do know of patients who kind of had great relief from homeopathy as well. So my last word would be no harm in trying it all. We don't really care what works, as long as something works.
True.
So you remember last week we were both speaking on an online forum on the management of adenomyosis.
Right.
So why don't we summarize the same for our listeners here? Can adenomyosis be managed? We've already spoken about what is adenomyosis in our last podcast. So can adenomyosis be managed? And if yes, how? And if no, then what can one do?
Okay, this is actually a very tough nut to crack, Rajeev. Adenomyosis can be quite stubborn. Surgical management can be done, but it's technically quite challenging because the adenomyotic tissue is intertwined with the normal myometrial tissue of the uterus. It's not separate from it. It's almost like, roots passing through the soil. So it becomes quite challenging for us to completely remove it. Now, medical management is the only solution, but that too doesn't work all the time. We try hormonal medications like Mirena, drugs like letrozole, cabergoline, and keep fingers crossed that, at least something will work.
Very true.
Once adenomyosis progresses beyond a point, the menstrual bleeding becomes quite heavy and painful, and the scary part is it doesn't respond to hormones after a point. Thus, sometimes it might, in the worst case scenarios, women have requested for removal of uterus at a very young age also because they're not able to bear the pain. Now, Mirena is the best bet available. Just to give a little more details, Mirena is an intrauterine device, that's an IUD, which releases progesterone hormone daily in very small quantities into the uterine cavity. It is inserted into the uterine cavity and thereafter left there for 5 years. The simple device can control both endometriosis and adenomyosis as well.
Absolutely.
Most of the patients I think have a concern with respect to consuming tablets over a long period of time. I convince my patients saying that whenever we take a pill or we consume a pill orally, only about 30% of the drug will finally reach the target organ. Whereas in Mirena, the main advantage is the entire dose of effective drug is released directly into the target organ. And that's the reason why, they don't experience any sort of major side effects or symptoms.
So, Apoorva, before we end this podcast, let's have some rapid fire questions that I have received from the listeners.
Okay, let's do it.
So, is there a cure for endometriosis?
There is no cure for endometriosis, but there are many treatment and management options to greatly improve patients' quality of life. Rajeev, pain during periods is a symptom of endometriosis, but that is such a common complaint for women. How do one differentiate?
Yes, it is true. Some bit of pain during periods is quite common, but when that pain is so severe that it hampers day-to-day life, it is increasing in severity over time, or is persistent throughout the month with aggravation during periods, is when one should seek a doctor's help to rule out the possibility of endometriosis. So, what kind of doctor should one see if one suspects that they have endometriosis?
It is important to talk to an OBGYN about any symptoms related to your reproductive health. Do not be afraid to seek a second opinion if you do not receive the care that you feel that you deserve. Can pregnancy stop the progression of endometriosis?
Only temporarily. Pregnancy and the increase in progesterone levels often relieve the symptoms, but they typically return after birth and or after stopping breastfeeding.
True.
So, how and why does endometriosis cause infertility?
Researchers are still trying to understand the exact relationship between endometriosis and infertility, but endometriosis is one of the top 3 causes of female infertility. Many women are unaware of their infertility or endometriosis until they actually attempt to get pregnant. In some women, endometriosis goes untreated, and the disease progression allows the endometrial tissue to block the fallopian tubes and inhibit ovulatory function. Some studies also suggest that endometriosis may alter the uterus in a way that disrupts embryo implantation. However, this notion requires more research. I tell my patients that from a female perspective, we need a uterus, fallopian tube, and ovary for pregnancy, and endometriosis can affect adversely all these 3 parameters. So, what is the cause of endometriosis? Are women born with it?
Research is still going on to determine the exact cause of endometriosis, and I think you spoke extensively about that in the previous podcast. We won't elaborate, but some studies have suggested a genetic component. So, can endometriosis be inherited?
So, more research is necessary to fully understand the genetic characteristics of endometriosis. With one first-degree family relative affected, that is either the mother, sister, or daughter, a person has an increased risk of having endometriosis. So, are there any links between endometriosis and cancer?
Not really, I would say. We do see a lot of endometriosis in India. You and I deal with it almost right through every day of the month and month of the year. But we don't really see endometriosis turning into cancer, and that's not what the books teach us as well. However, this is an area of research that is just beginning to expand. So time will tell, but in all likelihood, endometriosis does not lead to cancer.
Sure.
So if you get a hysterectomy, that is removal of your uterus, will the endometriosis pain stop?
So when the uterus is removed, there is no longer any chance of becoming pregnant. But we do not recommend a hysterectomy as a sound treatment option for endometriosis. Pain associated with endometriosis does not necessarily stop when a hysterectomy is completed, as the ovaries continue to produce estrogen, facilitating disease progression. Additionally, lesions may still be found on other organs, perhaps unrelated to reproductive system, which may cause other symptom manifestation. So, can birth control pills cause other problems like blood clots?
Well, any medicine can have side effects, and birth control pills are no different. They also have their own range of side effects. two points I would like to mention here, that many patients say that the problems of birth control pills are actually much easier to manage than the symptoms of endometriosis. So they would rather go with the birth control pills than with the pain of endometriosis.
Right.
Regarding blood clots, again, when we talk about Asians, we have a much lesser chance of developing blood clots as compared to Caucasians. So if you're talking about the Asian population, you can very safely go ahead and give oral contraceptive pills. In fact, this is just one question which I answered on Instagram this morning, because someone was writing with a lot of queries and a lot of anxiety regarding blood clots of oral contraceptive pills. So no, one can very easily go ahead. However, the risks of any medication or intervention must be discussed with the doctor who's prescribing these pills.
Sure. I think certain patients have a higher risk for developing these blood clots, and so we need to kind of alter the medication. And that's precisely the reason why the kind of medication that you should take should be specifically tailored for you by your doctor. You can't start taking the same medication just because your sister also had endometriosis and she's being prescribed them.
Right. So although these are common problems, yet, I was surprised when I saw this question. How is endometriosis different from uterine fibroids?
So the major difference between endometriosis and uterine fibroid is that fibroids are typically masses or lumps that are there in the uterus. Endometriosis is present essentially outside of the uterus. As I said, if the endometriosis is present in a particular part of the uterus, we call it as adenomyosis. So there's definitely a difference between all the three. More specifically, uterine fibroids are developed from one single cell of the uterus, and they have just kind of grown massively in size, or they kind of grow out of proportion, and that's how fibroids are formed, as compared to endometriosis, which essentially is formed more from the menstrual blood that is being accumulated at different parts of the body. And most of the times, I think it's the symptoms that differentiate fibroids from endometriosis, because typically uterine fibroids remain silent and don't have any major symptoms, as compared to endometriosis, wherein 80% of them have severe pain as the common symptom.
True, we usually follow a dictum saying that, if the fibroids are not bothering you, don't bother the fibroids, just let them be. But that doesn't really happen in the case of endometriosis.
Absolutely. So how is endometriosis different from any other ovarian cyst?
So ovarian cysts can be of various types, but basically if you say that ovarian cysts are typically caused when the egg releasing follicle in the ovary continues to grow, so that balloon which contained water and the egg inside, it tends to grow because of whatever reason, and they remain in or on the surface of the ovary, usually harmless, at the most can rupture or cause pain because of twisting, etc. But these are nothing compared to the endometriotic cyst which might happen. But that is more because of bleeding happening inside these cysts, and they're kind of very rapidly growing as well. Not rapidly growing as in terms of cancer, but rapidly growing wherein more and more blood fills inside them, and the cyst size tends to grow. And the symptoms also from these endometriotic cysts or chocolate cysts are far more severe than the simple cysts that we see in the ovary. Can endometriosis be transmitted through sex or a person-to-person contact?
Okay, absolutely no. Endometriosis is not a sexually transmitted disease, so that's why it can't be transmitted through sexual contact or by a physical contact from person to person.
This is superb, Apoorva. I'm so glad we did this. And with that question and answer, it's a wrap for part 2 of the endometriosis series with Dr. Apoorva Pallam Reddy. Looking forward to part 3 in this series very, very soon.
Thank you so much, Dr. Rajeev. It's always a pleasure to do the podcast with you, and hopefully we've given a lot of information to our listeners regarding pain management in endometriosis.
Right, so this brings me to the end of yet another podcast episode. I hope you enjoyed listening to it as much as we enjoyed making it. Thank you for all the reviews and suggestions. You're making our work so much easier and so much better. If you get a chance, do look up my website www.drrajeevagarwal.co.in and the associated blog. I also have a YouTube channel in my name. Do email me on fertilityWithoutBorders@gmail.com if you have any queries or if you want me to create a podcast on any topic of your choice. This podcast is available on Anchor, Headphones, Spotify, Breaker, Google Podcast, Overcast, Radio Public, as well as Apple Podcast. Do subscribe on any one of them or on Apple Podcast and leave your comments and suggestions. Looking forward to great interactions. Keep listening.